Welcome to the Rare Wellness Podcast. The pressures of this modern life, society, and world often steer us toward unhealthy lifestyles. Wellness is a rare treasure, hidden in a maze of daily challenges. In this podcast, we illuminate uncommon pathways to health and vitality, exploring cutting-edge ideas in regenerative, longevity, and performance medicine, all delivered in bite-sized segments. I'm your host, Dr. Jamie Lewis. And today we're diving into something incredibly important: how to choose the right GLP-1 provider and why not all clinics offering these medications are actually practicing real medicine. I'm joined today by Becca Pabon, one of our performance medicine nurses here at the Center for Regenerative and Performance Medicine.
Hi everybody, this podcast is brought to you by the Northwest Center for Regenerative and Performance Medicine, located in the beautiful Pacific Northwest. Visit us online at www.c4rpm.com.
Before we begin, a quick disclaimer. This podcast is for educational purposes only and is not intended as medical advice. Always consult a qualified healthcare professional for any medical concerns or treatment. GLP-1 receptor agonists, semaglutide and tirzepatide, have fundamentally changed the landscape of medicine. The STEP 1 trial, published in the New England Journal of Medicine, showed a mean weight loss of 14.9% over 68 weeks with semaglutide 2.4 milligrams, compared to 2.4% with placebo. The results have been, by any historical standard, extraordinary. But Becca, what we keep seeing is that patients assume all GLP-1 clinics are providing the same level of care.
And they're just not even close. Where you get these medications and how they're monitored can determine whether you actually improve your metabolic health or quietly create new problems that won't surface until months later.
Let's talk about one of the biggest red flags we see: online clinics and discount pharmacies that treat GLP-1 prescribing like an Amazon checkout. A recent study in JAMA Network Open flagged safety concerns with no prescription online semaglutide purchases, finding minimal medical oversight and inconsistent product quality. That alone should give patients pause.
A lot of those places are focused on one outcome, making the number on the scale go down. There's typically no baseline lab work, no body composition analysis, no muscle tracking, and no long-term metabolic strategy.
And that's where the danger lies. These medications profoundly suppress appetite. Patients are eating far less than they realize, often well below the threshold needed to maintain essential lean tissue and adequate micronutrient intake. A November 2025 article in the International Journal of Obesity from Nature specifically called out the missing pillar of nutritional support in GLP-1 prescribing, noting that early satiety and reduced dietary variety put patients at significant risk for deficiencies in iron, B12, vitamin D, calcium, and thiamine. Without hands-on guidance, the kind that comes from in-person clinical teams, patients can develop muscle loss, nutrient deficiencies, fatigue, and even increased frailty. And they may not connect any of those symptoms to their weight loss medication.
Muscle loss is the part that concerns me most, and the data backs this up. The STEP 1 body composition sub-study, published in the Journal of the Endocrine Society, found that total lean body mass decreased by 9.7% in the semaglutide group. A 2025 analysis in Cell Metabolism was even more specific. In STEP 1, lean mass was reduced by approximately 6.9 kilograms out of a total 15.3 kilograms weight loss, meaning roughly 45% of what patients lost was lean tissue, not fat.
And that number is critical because it exceeds what researchers call the quarter fat-free mass rule, the long-standing principle that about 25% of weight loss is typically lean tissue. With GLP-1s, we're seeing nearly double that proportion in some patients who aren't exercising.
And here's the part that scares me clinically. The scale still looks great, so the patient thinks everything is working. They see the weight dropping, they feel validated, and nobody is checking what's actually being lost.
Until they stop the medication.
Right, and because they've lost muscle, which is the primary driver of basal metabolic rate and glucose disposal, their metabolism has fundamentally slowed. That makes long-term weight maintenance dramatically harder.
The Step 1 trial extension confirmed this. 1 year after discontinuing semaglutide, participants regained 2/3 of the weight they had lost, and most cardiometabolic improvements reverted toward baseline. A 2025 meta-analysis in eClinical Medicine from The Lancet pooled 18 RCTs and found a mean weight regain of 5.63 kilograms after GLP-1 discontinuation, with longer follow-up periods showing even greater rebound, up to 7.31 kilograms. That's not because the medication failed, it's because the metabolic foundation wasn't built while the medication was doing its job.
Exactly. Weight loss without metabolic health restoration is temporary.
If you look at the two landmark studies used for FDA approval, the Step 1 trial for semaglutide and the SURMOUNT-1 trial for tirzepatide, these medications were never used in isolation. They were paired with a lifestyle intervention.
But when you really examine what that lifestyle component entailed, it was a 500 calorie per day reduction and a recommendation for 150 minutes of physical activity per week.
And that activity recommendation could be satisfied by walking alone. Now, walking is excellent for cardiovascular health, but it is not a stimulus for skeletal muscle growth or preservation. The European Association for the Study of Obesity's Physical Activity Working Group has specifically highlighted that resistance training, not aerobic exercise, is what attenuates lean body mass loss during weight loss diets.
This is a crucial distinction. The FDA trials showed what the medication could do, but they did not demonstrate what optimized care could achieve. And without resistance training, many patients will inevitably regain weight once they stop the medication because their metabolic engine, their muscle mass, has shrunk.
And this is exactly where the quality of your provider becomes a deciding factor. Another major shortcoming of the trial protocols was their heavy emphasis on calorie restriction rather than protein optimization.
In our clinic, we don't ask patients to count calories. We have them prioritize protein intake above all other macronutrients. Why? Because you cannot build or maintain skeletal muscle without adequate protein. It provides the essential amino acid substrate for muscle protein synthesis.
The evidence here is compelling. A 2025 case series published in PMC followed patients on semaglutide or tirzepatide who combined resistance training 3 to 5 days per week with protein intakes of 1.6 to 2.3 grams per kilogram of fat-free mass per day. The results were striking. One patient lost 33% of body weight, but only 6.9% of lean soft tissue. 2 patients actually gained lean tissue, adding 2.5% and 5.8% respectively, while losing significant fat.
Compare that to the trial data where 40% or more of weight loss was lean mass. The difference? Structured resistance training and protein prioritization. These are interventions that require in-person guidance, body composition monitoring, and individualized coaching.
A prospective study of 200 adults presented at a major 2025 conference found that when patients received education on resistance training and protein intake at the time of GLP-1 initiation, they lost approximately 13% of body weight, but only about 3% of their muscle mass over 6 months. The lead researcher specifically stated that this reinforces the importance of these medications being used under the care of experienced providers.
And when you're eating enough protein, you naturally tend to reduce calorically dense, high carbohydrate foods. You create a caloric deficit without extreme dieting, and that's sustainable. That's something patients can maintain after they stop the medication.
GLP-1s should never be used as a hack for crash dieting. They should be a stepping stone, a pharmacological bridge that helps patients transition into a healthier, metabolically resilient state. They're a tool, not the strategy. GLP-1s get all the media attention, but comprehensive metabolic care requires adjuvant support. Let's talk about some of the therapies we pair with these medications.
One of the cornerstones of our protocol is MIC injections, methionine, inositol, and choline. These are lipotropic compounds that support hepatic fat metabolism and bile flow.
That matters because when you're mobilizing stored adipose tissue at the rate these medications produce, your liver has to process and transport that fatty acid load efficiently. Without adequate lipotropic support, patients can experience sluggish metabolism, fatigue, and plateau.
And we also routinely supplement B vitamins, especially B12. The International Journal of Obesity article I mentioned earlier specifically flagged B12 as a nutrient at high risk of depletion in patients on GLP-1 therapy due to dramatically reduced oral intake.
Low B12 can present as fatigue, cognitive fog, peripheral neuropathy, numbness and tingling in the extremities. These are symptoms patients often don't connect to their weight loss medication, and an online clinic doing no lab monitoring will miss them entirely.
In our practice, we typically use methylcobalamin, the methylated bioactive form of B12, because it has superior neurological bioavailability compared to cyanocobalamin.
This is about getting healthier, not just smaller. If your provider isn't monitoring these markers, they're not practicing comprehensive medicine.
We're also routinely checking and optimizing vitamin D levels.
Vitamin D is far more than a bone health marker. The vitamin D receptor is expressed in skeletal muscle, pancreatic beta cells, and adipose tissue, all key sites in glucose metabolism. A meta-analysis in Scientific Reports involving over 12,000 participants found that vitamin D supplementation was associated with significant reductions in fasting insulin, glucose levels, and HOMA-IR scores, suggesting a meaningful role in insulin sensitivity. And a comprehensive review in PMC demonstrated an inverse association between vitamin D deficiency and insulin resistance across multiple populations. Low vitamin D can impair muscle recovery, slow fat metabolism, compromise immune function, and disrupt hormonal balance. An optimal vitamin D level of 40 to 80 nanograms per milliliter, well above the conventional normal threshold of 30 nanograms per milliliter, should be targeted.
And here in the Pacific Northwest, if someone isn't actively supplementing, odds are they're deficient. We see it in the lab work constantly.
This is why objective lab data matters. You cannot optimize what you do not measure. Guessing is not medicine, and no amount of telehealth convenience replaces serial laboratory monitoring with a clinical team that understands how to interpret the results. One of the most important clinical tools we use, and one that online clinics almost never employ, is serial body composition analysis.
Because the scale tells you one number, total weight. It doesn't tell you what you're losing: fat, muscle, water, bone density. Without body composition data, you're flying blind.
We use in-body bioelectrical impedance analysis to track lean mass, visceral fat, total body fat percentage, segmental muscle distribution, and hydration longitudinally over time. Visceral adipose tissue, the metabolically active fat surrounding the abdominal organs, is the dangerous fat. It's the fat most strongly associated with insulin resistance, type 2 diabetes, cardiovascular disease, and systemic inflammation. If scale weight is declining but visceral fat isn't decreasing proportionally, or if muscle mass is dropping disproportionately, that's a clinical red flag that demands intervention.
And without objective body composition data, you'd never know. The patient feels great because the scale says 180, but they may have gone from 30% body fat to 28% while losing 8 pounds of muscle. That's not progress. That's metabolic regression dressed up as weight loss.
This is the clinical nuance that separates comprehensive in-person metabolic medicine from transactional online prescribing.
Another critical gap with online clinics: they rarely evaluate the hormonal axis.
Hormones are the master regulators of metabolism, body composition, and energy. Low testosterone, which affects roughly 50% of obese men according to published data, drives increased adiposity, decreased lean mass, insulin resistance, and fatigue. It creates a vicious cycle. Obesity suppresses testosterone via increased aromatase activity in adipose tissue and disruption of the hypothalamic pituitary gonadal axis. And low testosterone further promotes fat accumulation. A systematic review and meta-analysis in the European Journal of Endocrinology confirmed that body weight loss in obese men is associated with significant increases in both total and free testosterone, but that normalization often requires substantial weight reduction. This means that for some patients, concurrent hormone optimization can be the catalyst that makes everything else, the exercise, the protein, the fat loss, work more effectively.
And it's not just testosterone. Estrogen imbalance, elevated cortisol, thyroid dysfunction, all of these can impair fat loss and accelerate muscle wasting. Without evaluating the full hormonal picture, GLP-1s are treating the symptom, while the metabolic root cause persists uncorrected.
Right. Every patient should be evaluated for optimal fasting insulin, below 6 microunits per milliliter, HbA1c below 5.7%, and optimizing testosterone in both men and women. These are the kinds of markers a comprehensive clinic is monitoring, not just prescribing a medication and hoping for the best.
When hormones are optimized alongside GLP-1 therapy, the entire trajectory changes. Patients build muscle more readily, recover faster, sleep better, and maintain their metabolic improvements long after the medication taper.
Let me synthesize what we've been discussing because I think the contrast is stark. An online clinic typically offers a 10-minute video call, a prescription, and a check-in via text message in 30 days. No labs, no body composition, no hormone panel, no nutritional assessment, no physical examination. A comprehensive in-person metabolic medicine clinic like ours offers serial laboratory monitoring, in-body body composition tracking, individualized protein and macronutrient guidance, resistance training programming, hormone evaluation and optimization, adjuvant nutritional support, including MIC and methylated B vitamins, vitamin D optimization, and ongoing clinical oversight by a physician-led team.
The research is clear. Combining GLP-1 therapy with structured lifestyle changes, especially resistance training and adequate protein, produces fundamentally better outcomes than medication alone. But these interventions require clinical expertise, objective measurement, and ongoing patient engagement. You can't get that from a chatbot and a monthly prescription refill.
A 2025 review in Frontiers in Clinical Diabetes and Healthcare put it perfectly. Future obesity management will prioritize integrated approaches that combine pharmacotherapy with lifestyle interventions, rather than replacing lifestyle changes with medication alone. That's not a prediction. That's the standard of care. And any clinic that isn't meeting it is practicing substandard medicine, regardless of how convenient the experience feels.
So if you're choosing a GLP-1 provider, ask yourself these questions. Are they running baseline and serial labs, including metabolic panels, hormones, vitamin D, and inflammatory markers? Are they tracking your body composition, not just your scale weight? Are they providing individualized nutrition guidance focused on protein adequacy? Are they evaluating and optimizing your hormonal status? Are they building a long-term metabolic strategy or just writing a prescription? Because without those elements, without nutrition strategy, laboratory monitoring, body composition tracking, and hormone evaluation, you're not restoring health. You're chasing a number on a scale.
And weight loss without health doesn't last. The data proves it. Thank you for joining us today on the Rare Wellness Podcast. If you found value in today's episode or learned something new, please subscribe, leave a review, and share this podcast with a friend. Your support helps us continue to provide free content to empower you on your journey to better health. This is Dr. Jamie Lewis reminding you that your body holds incredible potential to heal, thrive, and perform. Sometimes it just needs the right team, the right tools, and the right science to unlock its full potential.
For more information on the topics we covered today, visit www.spokanehrt.com. We'll see you next time.